Hey everyone. So today we're going to be talking a little bit more in depth about upper motor neurons and lower motor neurons and the role that they play when it comes to spinal localization. So let's start by kind of reviewing what these upper and lower motor neurons are. So upper and lower motor neurons, remember, are going to be the neurons that play a big role in motor movements, tone, reflexes, etc. And so our upper motor neurons live up here in the cortex of the brain as well as in our brain stem. Now, when I think of these guys, I think the best way to think of upper motor neurons is going to be as supervisors. So upper motor neurons serve as supervisors. Now, just like supervisors, a lot of times, sometimes I should say, they don't know exactly how to run the machinery, right? They do a great job of saying, hey, this is how we run it. But if you ask them to go and run it, it doesn't go well all the time. So these particular supervisors know nothing about how to run the machines. And in our case, the machines are our legs. But what they're very good at doing is telling our workers, which are our lower motor neurons, what to do. And so in this example, our lower motor neurons are going to be our workers. And so they are going to actually do two things. They know how to create reflexes. And by create, I should say that they facilitate reflexes. And so they take the sensory information from the body. They're like, hey, that could hurt. That stove could be really hot. I'm going to go ahead and pull this leg away. And they're going to facilitate that motor component of the reflex. And again, a reflex is a signal that goes up from the sensory information right straight down to the gray matter neurons and then down the ventral horn and out to the motor pathways so that you can actually make motor movements. And so that's going to be one of their primary jobs that they're really good at doing. So workers know how to make reflexes and they know how to make tone. All right. They also know how to make the muscle move, but what they don't know is when. And that's actually where our supervisors come into play. The supervisors are really good at saying, hey, this is when we're going to move. So these are the only guys that initiate movement. And by initiating movement, what they're doing is they're telling our workers, or our lower motor neurons, to, hey, change how you're creating your retone, change how you're affecting these reflexes, and through that modality, that's going to allow the limb to move. What's vitally important to remember is that lower motor neurons alone, because they're workers, cannot make decisions regarding initiating movement. In contrast, supervisors alone cannot make the machines work, so they cannot facilitate reflexes and they cannot facilitate tone. Now, as a reminder, we have lower motor neurons throughout the entirety of our spinal cord and within the brainstem. Within the brainstem, those lower motor neurons are going to be controlling our cranial nerves. We're not going to be talking about that particular subset of lower motor neurons today. For our lower motor neurons in C1, C5, so depicted here by our gray, and in T3L3, they do exist. We don't care that much about them from a clinical perspective. The main reason that we don't care about them from a clinical perspective is because they innervate things like ab muscles, all right? And honestly, nobody's out there running dogs through, a muscle man contest. And so we don't really care clinically about these dogs' abs, all right? And on a personal note, I wish people would stop caring about human abs because that would really benefit me as a person. But that's a story for another day. All right. So all of these lower motor neurons, again, we don't care about the T3L3, so let's go ahead and get rid of those. What we do care about are our lower motor neurons who live at C6T2 and at L4 to S1 and S1 to S3. All right, remember, not everyone separates L4S1 or S1S3, but from a learning perspective, I actually do think it's actually more beneficial to pull out S1, S2, S3 and its functionality because it's going to provide innervation to the booty hole, aka the anus, and the tail. All right, and so what is really important is that you can have damage just to those neurons or those nerve roots and only see damage to the anus, the tail, but you can't, while you can only see damage to those structures while the legs are actually intact. Now, when you have damage to L4, S1, and S1, S2, S3, remember that as we get towards the end of the spinal cord, all of those spinal cord segments start getting really small and compressed. And so they actually are really, really, really close together, which is why that spinal cord, when you have a lesion at like L5, L6, or even L3, L4, like a disc herniation, and it ruptures, you actually often will see L4 all the way to S3 lesions, and that's why they get lumped together, is because clinically you often see them play hand in hand. However, on other occasions you can see S1, S2, S3 be all by itself. So I just want to give it the respect that it's due, and oftentimes gets ignored. So as we jump in here, remember that we have these lower motor neurons who are living in specifically C6T2, L4, S1, and those are the ones we're going to start by focusing on, and we'll swing back around S1, S2, S3 in a little bit. So when we talk about these lower motor neurons at the level of C6T2, remember their jobs is to create reflexes and create tone. All right, that's what they know how to do, and they will only modulate how much reflexes and tone based on the upper motor neurons. So a good thing to remember is that these upper motor neurons that are telling the workers what to do, they're often telling the workers, hey, don't create too much reflexes and tone because we don't want an over surplus. And so this is a great way to remember that the cerebrum as a whole, our upper motor neurons, provide inhibitory signal down to the lower motor neurons. And it's that inhibitory signal that actually keeps the body from being continuously in a hypertonic state, and something that we see clinically, so that if we have like a lesion of the brainstem that actually, from a disease perspective, disrupts all of the communication from the cerebrum down to the spinal cord, you lose that inhibition, you lose the supervisor saying, hey guys, don't make too much, we don't want a surplus. And then you get an increase in tone clinically, because now the lower motor neurons or the workers are like, well, we only know how to make tone and reflexes, and we're going to do a lot of that because we're really good at it. Because the upper motor neuron's not there to say, hey guys, tone it down. And so clinically, when we have a decerebrate posturing, you will see increased tone in all the legs, also in the neck muscles as that kind of goes into opslotonus. And so those are some of those things. So the big takeaway there is that the upper motor neurons from the cerebrum go down and they tell the workers, hey, please don't make too much, otherwise we're going to have a surplus, and that would be a problem. Okay? Now, all of these upper motor neurons are going to have to communicate with all of our lower motor neurons, and this is going to be through a lot of our axons and our white matter tracts. Okay? And so they're going to travel throughout the spinal cord. These guys are going to travel in the periphery of the spinal cord, specifically in the white matter that surrounds the gray matter. Remember, the white matter is superficial when we are talking about the spinal cord. That is flipped when we're talking about the brain. And so what can happen is when we have a spinal lesion, such as at C1, C5, what we're actually disrupting is these axons that are traveling through the spinal cord. All right, and so let's start talking about what happens when we have some of these lesions. Okay, and so when we have a lesion, I'm going to go ahead and pick a fun little color here. I'm not quite sure which color. Let's use blue, since we've kind of used that for the brain, and we're going to be kind of not using that currently for the spinal cord. So when I have a lesion here at C1, C5, okay, oftentimes this can be a disc herniation, cancer, meningomyelitis, things like that, things that are causing damage to the spinal cord. We're going to see issues down the road, okay? And so what we see here is when we have a lesion here, we have now disrupted those white matter tracts that are traveling through C1, C5 from the brain down to the lower motor neurons. All right, and so we basically have effectively cut off the supervisors from the workers. And so what we'll see then, we term this as upper motor neuron signs. Okay, and so you'll see that people talk about that, saying that, oh, my thoracic limb is now going to have upper motor neuron signs, and my pelvic limbs will have upper motor neuron signs. And I'd like to talk a little bit about what that means. And sometimes I find this phrasing to be very confusing, right? That you're like, wait, I have an upper motor neuron lesion, but now I have upper motor neuron signs. And so it sounds like the upper motor neuron is playing more of an effect. And so the way that I actually am going to rephrase this structure is that I have a C1, C5 upper motor neuron lesion. And so I'm seeing signs consistent with damage to the upper motor neuron system. All right. And so that's another way of thinking about it. So when we're saying, hey, this limb has upper motor neuron signs, what we're saying is this limb has a deficiency in upper motor neuron input, and that the signs are consistent with a lack of upper motor neuron input. And again, I find that to be very confusing in how that's worded. And so by saying, oh, this is a C1, C5 causes a lesion of the upper motor neuron tracts, leading to a deficiency of upper motor neuron input, that leads to what we call the upper motor neuron signs. And it's a deficiency of upper motor neuron input to those legs. And so when we talk about kind of what that upper motor neuron means in general terms, right? Upper motor neuron, upper motor neuron, get my pen here going. There we go. Upper motor neuron signs equals a lack of upper motor neuron input. And remember what happens when we have no upper motor neuron input. Our workers have no supervisor telling them, hey, don't make an over surplus, otherwise we're going to have to cut our prices to get rid of it. And so what's going to happen is that we're going to see either normal to increased tone or normal to increased reflexes. And so those are what we call upper motor neuron signs. Okay. Now, paresis or plesia can also play a role in this, but this has to do with the idea that as the upper motor neuron signs, or as the upper motor neuron signal comes from the top, it goes back to that ability of the supervisors being the only ones to initiate movement. So if I cut off the upper motor neurons or the supervisors at the level of C1, C5, now they cannot tell the workers how to modulate their reflexes and tone, and so motor movement will not happen. Or if we're dealing with partial damage, such as in paresis, it will happen at a decreased level. And so you kind of have to think of plegia and paresis separately from tone and reflexes, because they kind of have a little bit of a difference. In comparison, when we talk about lower motor neurons and their motor function, they have to be present because they're the ones who actually have to make the modulations to the machine through modulation of tone and reflexes. And so if they're not there, the supervisors can say, hey, move that leg till they're blue in the face, but it's just not going to happen because there's no one there to modulate that machine. And so in comparison, when we have a lower motor neuron sign, all right, aka lack of lower motor neuron input, what we get is when we lack lower motor neurons, that means we lack the workers, and the workers are good at two things, creating tone and creating reflexes. And so what we'll see is we'll see either decreased or absent tone and decreased or absent reflexes. And so those are going to be the big differences between the two. So again, with a C1, C5 lesion, the only thing that we're really hitting here is those white matter tracts that are going through the spinal cord as they travel down to the lower motor neurons of both the thoracic limb and the pelvic limb. Again, they are going to be affecting lower motor neurons, but they're affecting lower motor neurons that go to neck muscles and things that honestly, clinically, just don't show up very, very well. All right. So again, a C1, C5 lesion is going to lead to a lack of upper motor neuron input, which will lead to upper motor neuron signs, and thus your limbs will demonstrate an increased or normal tone and a normal or increased reflexes. During this time, remember that motor movement is also involved, and so when I lose the connection to the supervisors and either it's decreased or it is absent, depending on the severity that the messaging system has been damaged, that's going to lead to the paresis or lead to the absent motor, which is called plegia. All right, so that's the C1, C5. So let's take these principles and work our way down the spinal cord a little bit. All right, I'm just going to try to delete that lesion a little bit. Okay. So now we're going to focus on a lesion that's going to be around C6T2. Okay. So we'll go ahead and, yay, our neck is fixed. We did it, guys. All right. So now we're going to focus on a C6T2 lesion. All right. So a C6T2 lesion now, when we talk about what it's going to do, go ahead and pause this video and take a second and think about, okay, what clinical signs will I see if I have damage right here? All right, well, hopefully you took a second to pause, thought through this process. So if I have a C6T2, I'm going to cause damage to both the lower motor neurons in the gray matter and the white matter, okay? So if we draw our spinal cord up here, if I have a C6C2 lesion, remember I'm going to damage both that and then also the white matter. The white matter is where my upper motor neurons are coming from, and the gray matter is where my lower motor neurons are coming from. All right? So yes, you can get areas that only damage one or the other. Those are some special considerations that we'll talk about at other time points. But really the big takeaway is that often when we're talking about just general terms, a lesion at C6T2, and if it's affecting the vast majority of the cord, it's going to affect both the lower motor neuron and upper motor neuron systems. And so when we think about the limbs at C6T2, so let's think about the thoracic limb. At the level of the thoracic limb, we're going to say, hey, C6T2, that's where I keep lower motor neurons to the thoracic limb. If I have a lesion there, that means I'm going to damage the lower motor neurons. That means I'm going to have damage there, and I'm going to have lower motor neuron sign at the thoracic limb. Okay? Now, if we start looking to the pelvic limb, well, the pelvic limb is very similar to the scenario we just talked about with a lesion at C1, C5. At this level, we're still dealing with upper motor neuron white matter tracts as they travel through the spinal cord and are heading down to the lower motor neurons living in the pelvic limb. And so when we damage that white matter at the level of C6, C2, we're going to damage the upper motor neuron pathways, okay? And thus, when we damage the upper motor neuron pathways, we're going to have a lack of upper motor neuron input to the pelvic limbs, and this will give us upper motor neuron signs in the pelvic limbs. All right? So that's kind of what we're dealing with so far. And again, you can take all of those same conversations. And again, just to reiterate, at a C6T2 lesion, when I see lower motor neuron signs, which means I have a lack of lower motor neuron input, I'm going to have my decreased or absent tone and decreased or absent reflexes, as well as motor function being affected. When I look at my pelvic limb, when I have a C6 to T2 lesion, then I'm dealing with the lack of upper motor neuron input from damage to the white matter, and that's where I'm dealing with normal to increased tone and normal to increased reflexes. All right? So let's take this party even further. All right, I'm going to go ahead and draw that. I'll leave the spinal cord there for you. Let's go ahead and take this party further as we move down the spinal cord. So let's fix our cord here. Put back our white matter tracks. Yay, we fixed him. All right. So now we're going to go down and we're going to damage a T3L3 lesion. All right. Go ahead, pause the video, think through this, and what kind of lesions or what kind of clinical signs would you expect in the thoracic limb, and what kind of clinical signs would you expect in the upper motor neuron limb? Alrighty. Well, let's see how you did. So When we have a T3L3 lesion, all right, now we're dealing with a lesion that is affecting, again, both the upper motor neuron tracts and the lower motor neurons that live in the spinal cord. Again, we're in this T3L3 region, so I don't care about the lower motor neurons. I care about that upper motor neurons that are traveling in the white matter and those axons that are traveling and sending that supervisor's message down to the lower motor neurons who live in the pelvic limb. And so if I damage the upper motor neuron in T3L3 and I'm damaging that messaging system, that messaging pathway, that means my lower motor neuron workers are not getting the signal. And so what are they going to do? Well, without someone guiding them and telling them, hey, don't make a surplus, they're going to say, oh, I need to make tone and reflexes because that's what I know how to do. And so that's exactly what they do. And so we will get upper motor neuron signs, which is normal to increased tone or normal to increased reflexes in our pelvic limbs, because that's exactly what those lower motor neurons know how to do when no one is telling them what to do. So again, upper motor neuron signs. Now, let's talk about the thoracic limbs, all right? The thoracic limbs, if you think through it, this lesion is very caudal to the thoracic limbs, all right? And so when we have a caudal lesion, in theory, we're going to be looking to have normal thoracic limbs because that lesion is caudal or behind all of that pathway as it's coming down from it. So we're not affecting the white matter tracts. We're not affecting the lower motor neuron tracts that live in the thoracic limb in most cases. Now, let's talk about one situation, all right, and that is called Schiff-Sherrington. Schiff-Sherrington results from the fact that we have some middle management, all right, who wants to get involved between these workers and our upper motor neurons. So these middle management team members live at L1, L2, L3, L4, L5, okay? They're called border cells. These border cells live around that gray matter, and what's really weird is that they are living at L1 to L5, and their axons are traveling cranial to the thoracic limb to provide inhibition to the thoracic limb. So again, these are middle managers who are all of a sudden now providing inhibitory signal to the thoracic limb, who are saying, oh, by the way, I know upper motor neuron's telling you, but I'm running the schedule here, so I'm also going to be putting in some of this information. And so they also provide inhibitory signal to the thoracic limbs. And so when we have severe damage to the spinal cord, or let me rephrase, when we have significant damage to the spinal cord and our border cells are damaged, anywhere kind of in that L1 to L3, or their axons are damaged that are traveling in the white matter. So again, we're either dealing with the actual neurons of the border cells, or we're dealing with their axons as it travels up T3L3 to the thoracic limbs. But when these are damaged, that leads to a loss of inhibition. And when we lose that inhibition, now you're going to have increased tone. And so Schiff-Sherrington is often described as having paresis and upper motor neuron signs in the pelvic limbs and increased tone in the thoracic limbs, but everything else localizes to T3L3, such as your cutaneous trunci, spinal pain, things like that. Everything else should be T3L3 except for increased tone in the limbs. And in some cases, this tone can be pretty significant to where the animal can't actually rise on its own or falls over. How you tell the difference between this is you test those limbs. With Schiff-Sherrington, the only thing that should be increased is tone. Everything else should be normal. You should have motor function. You should have proprioceptive function being normal. You should have reflexes being normal. So everything except tone should be normal. So people often get this confused with a cervical lesion or like an upper motor neuron lesion. And so you have to look and say, okay, I'm moving my front limbs. Those are functional. I have no proprioceptive deficits. And I have pain at like T12, T13. My cutaneous trunci cutoff is kind of up at that level too. And so this must be a T3L3 dog that's displaying Schiff-Sherrington signs. And Schiff-Sherrington often talks about severe disease, but it does not add anything to prognosis. All right? So that is that. So let's go ahead and we're going to fix our lesion here. Yep. Put our white matter tracks back. Pull out our purple. That way we don't get that confused. All right. Actually, I don't know about you guys, but having a different color purple was going to bother me the rest of this video. All right. And then we'll go ahead and delete that lesion. Okay, perfect. So now let's talk about our lesions as we are dealing with, an L4. Okay, so go ahead and take a second and think about what you want to do with a lesion that is affecting L4 to S1. All right. So as you thought through it, let's think about what's happening with the thoracic limbs. All right, the thoracic limbs are cranial. Yes, we have technically border cells that live at L4, L5, but if we damage the L4, L5 border cells, we still have the L1, L2, L3 border cells that are providing enough inhibition that we don't necessarily see Schiff-Sherrington syndrome or posturing, with these L4, S1. And so our thoracic limbs are going to be normal. All right, but now we're dealing with a lesion at our pelvic limbs. And our pelvic limbs at this L4S1 is where we keep lower motor neurons to our pelvic limbs. And so if I damage there, I'm going to damage my lower motor neurons, and a lack of lower motor neuron input is going to lead to lower motor neuron signs. And so this is the first time that I'm going to have lower motor neuron signs in the pelvic limb. All right. This is the first, like I said, this is the first time we see lower motor neuron signs in the pelvic limb. Now, let's continue that lesion on further back a little bit to S1, S2, S3. All right. When you have that scenario, now you're caudal to everything, and if only S1, S2, S3 is damaged, and we'll typically see this with like really bad lumbosacral disease or things like that, things that aren't hitting L4 to S1, we're actually going to get normal. Oops. Sorry, the color change will bother me. We'll get normal thoracic limbs and normal pelvic limbs. Okay? And then we will lose innervation to the anus. So the big clinical signs of an S1, S2, S3 lesion is lack of anal tone and lack of perineal reflexes. You'll also see absent tail function. All right? But tail function should always follow the leg functions around the pelvic limbs, etc., except for this S1, S2, S3 when the tail may have absent motor function separate from the rest of the body. Now, let's talk about one other situation, and that's going to be lower motor neuron disease. So when I have systemic lower motor neuron disease like botulism or something affecting the neuromuscular junction or something like that, okay, and we're going to call that neuromuscular disease, what you might see in that scenario is lower motor neuron signs in both limbs. And I'm going to go ahead and encourage you that when you see lower motor neuron signs in the thoracic limb and lower motor neuron signs in the pelvic limbs, to be cautious and thinking, this is either a multifocal spinal lesion that's affecting both C6T2 and L4S1, or I'm dealing with a neuromuscular condition like botulism, polyradicular neuritis, tic paralysis, things like that. All right. And again, all of those conditions also can start off really early as just affecting like the back legs or just one of the leg sets over the other, and then progress to being fully lower motor neuron in all four limbs a day or two later. So again, this has just been kind of a very quick summary of upper motor neuron, lower motor neuron, how that plays in, what kind of clinical signs we see. As always, guys, I am here to facilitate your education. If you have questions, if this created more confusion than it did answers, please reach out, let me know. We can always sit down one-on-one or in small groups and talk things out, because I want you guys to feel comfortable with neurology, and don't let it feel overwhelming, don't let it feel scary, because I absolutely believe that we can get you where we need to. Okay, all right, guys, have a great rest of your day, and let me know if you have questions.